Hey folks, just want to note that it is 4:15, but I just want to give everyone a chance to hop on, so we'll get started here in a minute or two. Thanks so much. All right, I think we can go ahead and get started. Good afternoon, everyone. My name is Melinda Southard, and I serve as a Deputy Director here with the Nevada Health Authority for Community Engagement and Workforce Development. And one of the areas that I oversee, of course, is the statewide healthcare access and recruitment program. So just want to thank you all for joining the public workshop late this afternoon. We're excited to share a lot of good information with you. So with that, I'll go ahead and get into the slides. So of course we have an agenda. So first we want to just do a little bit of level setting, just give a brief overview of the statewide healthcare access and recruitment program. Then we'll move into a review of the draft initial assessment and report that NVHA is working on. Then we'll move into the outline for the request for application process. And then, of course, review the draft RFA for the SHARP program itself. And then we'll have an opportunity for questions and discussion at the end of the slides. So appreciate you all holding your questions until the end, and looking forward to answering those questions for you guys. All right. So first we'll get into a little bit of an overview about the statewide healthcare access and recruitment program. So this program came out of Senate Bill 5, otherwise known as SB 5, from our 2025 special session of the Nevada legislature. So the goals of implementing this program is really to support workforce capacity and sustainable healthcare in our state. So Senate Bill 5 in and of itself did create a new state general fund account. That's what the SGF stands for. So there's a new account to hold the funds that support this program. The Nevada Health Authority is assigned with developing the grant program that's associated with this program. And it also wanted to note here that we do have IFC, or Interim Finance Committee, approval is required on all SHARP grant awards. So that means that, all of the requests for, or actually all the applications that are received, the Nevada Health Authority, reviews those, and then there are selected grants or applications that will go forward for recommending for funding. So the Nevada Health Authority has to take those recommendations to the Interim Finance Committee for final approval. There is a one-time appropriation of $60 million in state general funds appropriated to the SHARP account. So we do have those funds available. They will not be available, though, until July 1st of this year. So right now we're just operating off of our normal operations. And then the bill also did allocate 3.5% to the Nevada Health Authority of the funds in the account to be able to administer the SHARP program. So some of the requirements that came out of the bill as well, we do have that biennial required SHARP assessment and report. So every other year, the Nevada Health Authority is responsible for getting that information out together and out to the public. And in addition, we do have very specific requirements for entities that are eligible for funding for this program, as well as projects that are eligible to be funded through this program. So then the implementation procedure of the Nevada Health Authority, we are compiling that initial assessment that's required before July 1st of 2026. So Dylan and Maddie will get into that in a little bit here. So they're also developing that report that is coupled with that assessment. And then the request for application, or RFA process, will be built upon the information that comes out of that assessment and report to then solicit for applications from you all to be able to subgrant out these funds. And then we also are asking for staff within the Nevada Health Authority to support administration and sustainment of the SHARP program. So I also wanted to provide a quick overview of some of the different workforce programs that we have in the Nevada Health Authority. So the SHARP program is just one of the healthcare workforce opportunities that we have available at this point. So I just wanted to go through these really that we do have a graduate medical education, or GME, program in the state. This has been around since about 2014. This program is statewide, and in this state fiscal year, so SFY 26, we have $15.8 million available to support creation, expansion, or retainment of residency programs and postdoctoral fellowships that are all approved by the Accreditation Council for Graduate Medical Education, otherwise known as the ACGME. And we did have the Advisory Council for GME did just meet earlier this month and provided their recommendations to the Nevada Health Authority for which applications should be funded. So the next step is for the Nevada Health Authority to review those recommendations and get to working on issuing those subawards by June 30th of this year. Next, we have the Rural Health Transformation Program, or the RHT program. One of the initiatives within the Rural Health Transformation Program is Workforce Recruitment and Rural Access Program, otherwise known as WRAP. We did allocate a vast majority of the funding that the state receives every year in this grant towards workforce, because we know that it is such a need in our state. The Rural Health Transformation Program, though, is limited to rural and frontier areas of the state per those HRSA definitions. So I did provide a link there that you can review and see, which areas qualify as rural and frontier in our state. So under this particular initiative, we have almost $72 million available in this first year, otherwise known as Budget Period 1, or BP1. That is from December 29th of last year all the way through October 30th of this year. So that's the budget period. And the next steps for this one is that the subawards are to be issued no later than October 30th of this year. And that's due to federal deadlines that we have to meet, where the state has to obligate all of those year one funds no later than October 30th. And then, of course, we have the SHARP program. The SHARP is available statewide. This year next year, I guess, state fiscal year 2027, which will start on July 1st of this year. We will have nearly $58 million available. And the reason why that is less than the $60 million is, of course, because we have that 3.5% available to the Nevada Health Authority for those administrative costs. And of course, the next steps for the SHARP program is that we are looking to issue the RFA before August 1st. However, my goal is to get the RFA published by July 15th. So fingers crossed, working on that. And then all projects recommended for funding, of course, will be subject to IFC approval. So with that, I'm going to turn things over to Dylan to go over the draft assessment and report for 2026.
Thanks, Melinda. Hi, everyone. I'm Dylan Malmlove, and I serve as the Executive Director of the Nevada Patient Protection Commission. And I'm joined by Madison Lope from the Office of Analytics and our Chief Biostatistician. Next slide, please. As required by SB 5, the Nevada Health Authority is required to conduct an analysis of the healthcare workforce in Nevada and determine the most critical shortages and unmet needs for health technology and therapies and workforce. The assessment aims to answer two broad questions: how many providers are practicing in the state by region and profession or specialty, and which professions or specialties and regions are experiencing the greatest unmet need. Next slide. There's been a significant amount of work in this space to this point, and in our analysis, we reviewed the literature to gain an understanding of the current trends and themes. Those sources can be found in the appendix later in these slides. But at a high level, the common themes that emerged were persistent and growing healthcare workforce gaps, that while there has been meaningful growth in the licensed healthcare workforce, the provider to population ratios remain well below national averages and may not be keeping up with the population's needs. Since 2000, the state's population has grown 63%, exceeding national growth rates, starting at about 2 million in 2000 to more than 3.3 million in 2024. During that time, population demographics have shifted as well. The population is aging, the median age has increased, and the share of residents over 65 is projected to expand substantially over the next 2 decades. That group is associated with higher healthcare utilization and needs. Further, the average age of physicians in the state is 54.8, and about 44% of active physicians are over the age of 55, raising concerns that workforce attrition or retirement may outpace our ability to train and recruit new providers. There are also geographic challenges. Carson City and the state's 14 rural and frontier counties together account for just 6% of the physician workforce and 11.4% of the state's population, spread across about 86% of the state's total land mass. These factors may contribute to access and quality gaps in the state, where Nevada ranks among the bottom states in metrics tied to coverage and access at 49th and prevention and treatment at 51st, according to the Commonwealth Fund State Scorecard. Some metrics that contribute to these poor health rankings include 27% of adults without a usual source of care and 15% of adults who went without care because of cost in the past year, and 42% of children without a medical and dental preventative care visit in the past year. Each of these factors help add context to the workforce shortages and identification of critical areas of need. Next slide, please. I wanted to quickly highlight our methods, beginning with kind of a statewide workforce supply analysis, showing the workforce supply across selected professions and physician specialties. In each of these tables, we'll show the active or licensed providers per 100,000 population, comparison to neighboring states including Arizona, New Mexico, Utah, and Colorado, and national benchmarks, location quotients, and estimated workforce gaps to reach national parity. And finally, county-level provider density maps for those selected professions. Using that data in our literature review, priority areas were selected, and those include primary care, behavioral health, and medical specialties. Within those shortage areas, we did a deeper dive looking at health professional shortage area designations and active Medicaid providers. Active Medicaid providers per 100,000 Medicaid beneficiaries, and the geographic variation in provider participation for those focus areas. We use data from multiple sources across the study, and those are listed here as well. Next slide, please. This first table shows selected professions across the healthcare workforce derived from the Bureau of Labor Statistics data from May of 2025 and the AMA physician professional data, and shows by profession the active providers in Nevada, then the rate of providers per 100,000 for Nevada, and for comparison states across the Mountain West, selected for their geographic proximity, demographic, and geographic comparability, and their similar Medicaid context. Those included Arizona, New Mexico, Utah, and Colorado, and then national per capita rates, which are used to calculate Nevada's location quotient, which take the per capita rates from Nevada divided by the per capita rates in the US. A location quotient above 1 means that you have more than the national average, and below 1 means you have yet less. Using that rate, we're able to calculate the number of additional providers needed to meet national rates. This slide helps show that Nevada's challenges aren't isolated to one profession, but are broad and systemic across much of the care continuum. There are a lot of numbers over the next few slides, so I just want to point your attention to a few areas. First, within the mental and behavioral health space, there are concerning shortages across community level frontline behavioral health providers like counselors and therapists, and needs among more acute care professions as well. For physicians and physician assistants, Nevada is among the bottom 2 states in regional comparison and fall short of national averages, with about 2,441 additional physicians needed and about 300 additional physician's assistants needed. Among nursing professions, data indicate substantial gaps and shortages across the Mountain West. It seems that Nevada's challenges aren't unique, but consistent with the need across the region, where about 4,000 additional registered nurses would be needed to reach national parity, as well as 2,800 LPNs and 4,600 CNAs. Another important takeaway is that the shortages aren't uniform. Nevada performs relatively better among nurse practitioners, which may reflect how the state's kind of adapted to physician shortages through expanded use of advanced practice providers. At the same time, though, those gaps in physicians, registered nurses, and behavioral health specialties suggest challenges across profession areas. Next slide, please. This slide continues a similar pattern, although shortages here are often more moderate and uneven across professions rather than across categories. A notable takeaway is that Nevada tends to perform better in professions tied closely to acuity and hospital-based care, like respiratory therapy and paramedics, where Nevada is closer to or at national averages, which could reflect more targeted workforce investment, hospital demand, acute care needs, and expansion of acute care capacity over time. In contrast, many of the rehabilitative and supportive care professions remain below national benchmarks, including things like physical therapy, speech-language pathology, occupational therapy, and pharmacists. These are increasingly important for managing chronic disease, aging populations, disability services, and post-acute recovery. While they don't often receive the same attention as physician shortages, they play a large role in long-term health outcomes. Next slide, please. This map helps contextualize the workforce shortages we discussed in the previous slides, showing how providers are distributed geographically across Nevada. It contains selected healthcare professions, and the full table is available in the appendix of this presentation and is from licensure data available on the Nevada Instant Atlas. Darker blue here indicates that a higher proportion of providers. Sorry, my light is on a timer. And then the lighter blue indicates fewer providers. While shortages are often framed as a rural issue, this map shows that challenges are broader, both distribution and supply. Provider concentrations are highest in urban areas because that's where the majority of Nevada's population and healthcare systems are located. However, Clark County, despite having the highest number of providers, still has relatively low provider to population ratios compared to Washoe County and national benchmarks. The map also reinforces that frontier and rural communities face access challenges, and in many of these areas, there aren't just long wait times, but limited or absent local access altogether, requiring them to travel long distances for care. Behavioral health disparities are particularly pronounced geographically and consistent with some of those earlier results and gaps. Psychiatric and behavioral provider supply is very thin across much of the state, including some of the urban regions, which suggests a broader statewide workforce pipeline and retention challenge rather than isolated gaps. I also want to point out that this is based on licensure data, so it may not be where care is actually delivered. Some providers may practice part-time across multiple locations through telehealth or in another state. So the effective provider supply available to patients may be a little bit different than this map represents. Slide, please. This slide starts to show where Nevada's physician workforce gaps are most concentrated. The shortages are broad and extend across primary care, behavioral health, and many of the core medical specialties. Primary care is a clear example, representing about 40% of the total physician workforce gap to the national average. And this has important implications as primary care is often the front door to the healthcare system. And when capacity is limited, patients may delay preventative care, experience longer wait times, or rely more heavily on acute or intensive care settings like emergency departments for routine care needs. The pediatric workforce stands out in particular. Nevada's pediatrician supply trails both neighboring states and national benchmarks, which may impact preventative services, developmental screening, and coordination of care for children with complex needs. And we may be seeing the impacts of those shortages in the state's health rankings, where the state ranks last in children with a medical home at just 32% with medical home status, which is having a usual source of care and support navigating referrals. 50th in children without a medical and dental preventive care visit, at about 2 in 5 without a visit. Behavioral health shortages remain among the most severe findings in the analysis. Psychiatric and especially child and adolescent psychiatry show some of the lowest provider ratios on the slide. These shortages are often associated with longer wait times, limited access, and greater reliance on emergency or crisis-based care. And again, these shortages may contribute to Nevada's poor mental health rankings, where the state is ranked 51st, according to Mental Health America. The specialty care data also suggests that Nevada may still be developing tertiary and subspecialty capacity. Fields like cardiology, pulmonology, neurology, gastroenterology, hematology, and oncology all remain well below national averages as the population grows and ages, and demand for these specialties will likely to continue increasing, particularly given the rising chronic disease and cancer prevalence across the nation. Next slide, please. This slide continues to show that picture of the physician workforce, focusing more on hospital-based diagnostic and surgical specialties. Compared to the prior slide, Nevada performs somewhat better in several acute and hospital-centered specialties, but those gaps still remain. Emergency medicine and anesthesiology are relatively closer to national benchmarks. Pathology and radiation oncology remain notably below national averages, consistent with some of the findings from the prior slide, suggesting ongoing challenges in cancer care infrastructure. The surgical specialties show a similar pattern of relatively more moderate, but still widespread shortages. Some of the largest relative gaps appear in specialized surgical fields like vascular and neurological surgery. It's also important to remember that these counts may not reflect the effective supply of physicians in the state. And taken together, these last two slides kind of reinforce that the state's workforce challenges span across the full continuum of care. Next slide, please. Again, this map builds on the prior slides by showing the physician licensure map from data available on the Nevada Instant Atlas, and shows how physicians are distributed statewide. The map reinforces that what the statewide and regional data show. Physician supply is heavily concentrated in Clark and Washoe counties, with rural and frontier counties operating at a fraction of the per capita levels needed to meet some of those access thresholds. Within the urban counties, though, Washoe County's physician density, which is about 323 per 100,000, is 43% larger than Clark County at 225 per 100,000. Slide, please. Through the analysis of the statewide workforce supply, quality, and access indicators, we identified 3 broad areas of need thus far. Primary care emerged as a foundational gap, with Nevada significantly below national physician benchmarks and representing 40% of the volume of physicians needed to meet national parity, and 65% of Nevadans reside in a primary care health professional shortage area. And because primary care serves as the entry point into the healthcare system, shortages here can contribute to downstream impacts on prevention, chronic disease management, emergency department utilization, overall healthcare costs, and strain on other provider types and the healthcare system. Behavioral health also stood out as one of the most significant statewide challenges. Nevada has among the highest prevalence of mental health and substance abuse issues and lowest relative access to care. The shortages across community level providers serving as the first point of contact for most individuals seeking behavioral health care is particularly concerning, as well as shortages across more intensive and acute care, where rural and frontier and underserved areas are extremely low and functionally absent, with 100% of rural and frontier counties designated as whole county shortage areas, and 91% of Nevadans living in a mental health professional shortage area. Finally, longitudinal medical specialty care gaps were identified as a growing concern. Several specialties critical to managing complex chronic conditions, including oncology, cardiology, pulmonology, and gastroenterology, remain well below national benchmarks and peer states. And as Nevada's population grows and ages, these gaps place increasing pressure on the broader healthcare system. I think this is where I'll hand it off to Maddie.
Hi, everybody. I'm Maddie. I'm the Chief Biostatistician with our Office of Analytics. So the next couple slides go into the areas of need, first focusing on primary care. So these maps kind of break down by region, and then over on the right-hand side, zoom in on areas to be able to see a little bit clearer. But as you can see, about 65% of Nevadans live in a primary care shortage area, and 12 of our 17 counties are in these shortage areas. So really, this is an issue that spreads across the state and is not centralized in just one geographical region. And then next slide, please. And then this slide here, still on primary care, but this focuses down actually on Medicaid specifically, that is utilizing claims data to identify how many providers are billing for services provided to the Medicaid population for primary care. In the table on the left, it goes into the specific profession within primary care to see how many active Medicaid providers there are, and then the number per 100,000 eligible Medicaid population. So here you can see really general practice and geriatric medicine have significantly lower rates than any of the other professions, but there are still shortages across all areas that impact primary care. And then the map on the right just shows total primary care providers by county, same as the maps that Dylan was showing. The darker shading is a higher rate per 100,000 population. So here, interestingly, you can see Clark County has a rate around 265 per 100,000, whereas Washoe is 478 and Carson is 795. So you can see there's a pretty big disparity in the urban regions. And then this will be kind of the theme across the board for the following slides as well, but in the rural areas, rural and frontier counties, we're seeing pretty significant shortages. Next slide. Next, going into behavioral health, about 91% of Nevadans live in a mental health shortage area, and that's 15 of our 17 counties. So again, very widely across the board, 100% of our rural and frontier counties are in a shortage area. And Nevada ranks 51st overall in mental health. So this really goes to show that lack of access to care, provider shortages really makes it difficult across the state for people to get the services that they need in behavioral health, and that does show in our overall mental health ranking. Next slide. And similar to before, this is breaking down behavioral health, so showing by profession. Clinical psychologists have the lowest rate here, whereas clinical social workers have the highest, but still pretty low rates per eligible Medicaid population. And then really similar as before, Washoe County has 2.4 times more providers per capita than Clark County. So really kind of emphasizing the shortage in providers in Clark. And then several of our rural and frontier counties do not have any providers at all. So if in order to access behavioral health services, they either need to access through telehealth or travel outside of their county to receive those services. Next slide. And then last, we have the medical specialties. So as you can see in the table, endocrinology and oncology have the lowest rates, although it is very low across the board. Clark County has the lowest density in our urban counties, but again, same pattern. Many or the majority of our rural and frontier counties don't have any providers at all in these areas. So again, would have to travel outside of county or region to be able to access services. Next slide. So some of the limitations that we have seen while doing this work, one is the cross-source comparability. So many different data sets, especially when comparing publicly available data, use differing methodologies, different reporting periods. Some have more recent data, whereas others don't. Some roll up their specialties into different categories using different definitions. There's just pretty wide inconsistency, I would say, that just makes it very hard to have direct comparability across these different sources. As has been mentioned previously, there's also a limitation with comparing licensure versus active practice. As Dylan was saying, just because a provider is licensed in a specific area does not necessarily mean that they are actively practicing. It doesn't indicate where they are practicing, and if they, like how much of their time they're practicing in a given area or even within the state. For Medicaid enrollment in activity, this is all based on claims that are submitted and billed to Medicaid. And so there, of course, is limitation in services that maybe are not being billed. So it's hard to, like, for example, if we don't have the data, it's hard to identify it. So if there may be a gap because people may not be going to get the services, that's not going to be reflected in claims data because there's not going to be a claim if they're not receiving the services. So that kind of limits the information that we have there. Geographic limitations. Many providers will often travel, especially in Nevada, to more rural or frontier areas. And so that may be hard to identify if, for example, their primary location is in an urban area, but they travel occasionally to one of our rural counties. That can be hard to identify. Telehealth utilization and how that expands access to care. And a lot of times going cross-county or state services. So a lot of times, like I mentioned, with our rural counties, people either are not able to get services within their county, so they have to travel to a different county, or sometimes, especially for some of our medical specialties, individuals have to travel outside of the state to receive those services. And then lastly, provider supply does not equal access. So population ratios don't account for the population need, appointment availability, capacity, wait times, all of that, like I was saying, is something that is not necessarily identifiable in claims data. And so we may have really limited information on that. Next slide, please. So lastly, our conclusions from the information presented here is that there are large workforce gaps, I think, across the board and across many different specialty areas, many different geographical locations, and really concentrated in preventative services, primary care, behavioral health, and medical specialties. Medicaid enrollment data suggests effective provider capacity may be more limited than the active provider counts indicate alone. Our findings support targeted workforce investments in high-need professions and underserved regions. And lastly, future iterations of the study should explore and expand across all payers. So like we mentioned, this is limited to Medicaid claims data specifically. Trends to see if there are improvements in certain areas. So for example, we may still have a shortage in a given provider specialty. However, there may be improvements from like recent investments that in that area that we could see. And then looking at utilization metrics to identify the needs that may not be apparent in claims data. And with that, I will pass it back to Melinda.
Perfect. Thank you, Maddie and Dylan. All right. So now I wanted to jump into the RFA process and just go over a timeline with you all for next steps. So on this timeline, you can see that we intend to publish the SHARP report before July 1st, so sometime in June. And also noting on here that our funds do become available after July 1st, so eagerly awaiting that date. And we intend to release the RFA for the SHARP grant program by July 15th. So I wanted to talk with you all about, the potential timeline that we could utilize in the SHARP RFA. Like, how long do we want that RFA open application period? So as I mentioned before, all the SHARP proposals that are recommended for funding are subject to final approval with IFC. So if we have an RFA release date goal of July 15th, we're looking at, making the deadlines for the December 10th IFC meeting. IFC does not meet every month, as many of you know. So the December 10th meeting, it looks like that's the earliest one that we could gain with the timelines that I'm going to go over. So for the December 10th IFC meeting, Nevada Health Authority has to have everything in and together for that meeting by October 7th. So if we need at the Nevada Health Authority approximately 4 to 6 weeks after the RFA closes to review, evaluate, and provide those final funding recommendations, 4 weeks prior to October 7th is September 9th. So that's a potential deadline for the RFA. Or 6 weeks prior to October 7th is August 26th. So that is another potential deadline for the RFA. So if you have the RFA open and it closes August 26th, that gives you 42 days to get the application together and submit a complete application. If we have it open to September 9th, that allows for 56 days of an open application period. So here I just wanted to pause and see if there are any initial comments, suggestions from the audience. So I'll be quiet for a minute, and if you want to use the raise hand feature, that would be great.
Melinda, there is a note in the chat that says 56 days preferable.
For sure, thank you. And Kiana?
Kiana, yeah, hi. Kiana Cole, Regional Chief Nursing Officer at Intermountain Health. Definitely, I would vote for 56 days if possible, but also not knowing what that RFA looks like, right? How involved it is or how long it is, so that we can make sure that we do a good job filling that out and to completeness. That would be my vote. Thank you.
For sure. Thank you so much. Any other comments? Yeah, Chrissy.
Yes, I second Kiana's 56-day preferable. Also, Chrissy Etheridge with Healthcare in Action. We are a street medicine program And my question is whether or not mobile care delivery models operating in this shortage designated areas qualify as addressing the workforce area gap or access gaps under SHARP's criteria.
Thank you for that question. That is a good consideration that we will take into account when developing the RFA. So I really appreciate you raising that now.
Thank you.
But thank you. Okay. All right. In the interest of time, I'm just going to move forward. So thank you for your comments. So in looking at the draft RFA, we're going to go over, the just reminders about the eligibility criteria, some of the statutory allocation priorities, and then I have another question for y'all. So the bill itself has some very specific requirements for who is eligible to apply for the SHARP funding. And those are listed here. We have healthcare facilities and clinics, higher education and training programs, behavioral health and substance use entities, oncology organizations, and government and nonprofit entities. And those each have, very specific subcategories, and all of this will be available in the RFA itself. So the RFA will go into detail on exactly who is eligible to apply for this funding. And additionally, the bill also had very specific eligibility requirements for the types of projects that would be eligible to be funded through this program. So under here, we have, looking for projects that expand workforce access and obviously expand the workforce itself, address certified areas of need, have measurable outcomes. That's really important, especially when we're tracking, progress of a project or success and outcomes of projects is really important. Also, the geographic focus, obviously the care is intended to be delivered entirely within the state of Nevada, and the bill does provide an exception for that if it is logistically unfeasible. And then lastly would be, sustainability, right? Because this program is funded with a one-time appropriation at this point. And so we're really looking for sustainability considerations in these projects and how they will continue to be carried out and benefit Nevadans. Some of the statutory allocation priorities. So the bill also reviews different types of projects that should be prioritized for funding. So the first priority would be projects that are addressing our most severe and immediate unmet healthcare needs. And that would be things like what Dylan and Maddie just presented to you all about what the severe needs are of Nevada. So that again will be defined within the RFA itself. Second priority, so going down the list, right, would be projects maximizing benefits directly inside the defined certified areas of need that would come out of that report through Nevada Health Authority. Third priority, projects physically based in a HRSA designated medically underserved area, HIPSA, or regions where at least 30% of the population is enrolled in Medicaid. And again, Dylan and Maddie gave us some great information on that. And then the last priority would be projects demonstrating a binding operational commitment that at least 10% of all patients served by the project are Medicaid recipients. So thinking about these priorities, we have that first priority tier, right? Those projects addressing the state's most severe and immediate unmet healthcare needs. Given everything that Dylan and Maddie have presented to you all today, is there anything that we are missing? Is there anything that the Nevada Health Authority should explore further in the data to support this first priority tier? And I just want to pause here and see if anybody has any comments, questions, concerns, thoughts about this question here. Yeah, Kate. I'm sorry, I'm gonna
It's
mispronounce
okay.
it again.
You can just call me Key.
Okay.
I think that it's kind of inferred under primary care, but definitely pediatric care is something Mountain is highly trying to improve in the state and with bringing our children's hospital. And so exploration of primary care, pediatrics would be just another area that is not called out so specifically, but we know through our research that that's a need in our state as well. May just be a subcategory of primary care.
Correct.
But it
Thank
really
you.
also includes a lot of specialty care as well, though, and those specialists that we do not exist right now within our state.
Thank you. All right, Dan, please go ahead.
Hi, Melinda. One of the things that we have been pursuing and talking to folks about here at the Valley Health System is, and there is a group out there that's working on retention of physicians. And I think that's something that we also need to be discussing and make sure that's, I don't know if it's first priority, but it's certainly, we know we have a graying of the workforce, but we also have incredible burnout. And I think all we can do to keep who we have already working in the state would certainly be important.
Thank you for that comment, Dan. Appreciate it. Connor.
Hi, Melinda. Sorry for the video from my car. I apologize for being on the go. Just two comments. One, I know that Medicaid claims data was referenced, and if it's possible to really drill down on that claims data to make sure that we're talking about services that otherwise could be provided in the state. And what I'm getting at more specifically is we want to make sure we're not capturing things like prescriptions that are being filled outside of the state, or for medicines, or things like eyeglasses, things that might make certain categories seem like a bigger need than they actually are, so they can really address the categories that are the true need. So drilling down a little bit further into that claims data, I think, is important. And then the other thing, I know this data is from May 2025, and it's hard to get more recent data, but if there's any way, particularly for some of the subspecialties, to make sure we're doing one final kind of swing through an analysis, I can say for us in particular, we've added a number of subspecialists over the past year or so. And for some of the services that we've talked about in the past, we're now providing those services, and that might not be reflected in the data that was collected in May 2025. So I wanted to flag that as well.
Yeah, thank you, Connor. Appreciate that. Any other comments? Yeah, Shauna.
There, this is
Sorry.
Shanna. You had it right.
Okay,
I'm
good.
Shanna with the Nevada Physician Wellness Coalition, and I just wanted to second what Dan mentioned about physician and clinician retention, just as important, if not more important, as recruitment, to make sure that we're keeping the clinicians that we have, and also, supporting them in navigating burnout, knowing that burnout can decrease patient outcomes and access to care.
Great. Thank you for that comment. Appreciate it. Any other comments? Okay. I do understand that we're 3 minutes over our time, so just want to open it up for any additional comments on what was presented today, any questions that you all might have, anything that we can be helpful with.
Melinda, it's Monica. There are two comments in the chat. The first one says, unrelated to data selection, will IFC be reviewing and approving applications individually, or will they be approving a slate put forward by NVHA?
Good question. I will take that back and find a way to post that information on our website and give you guys an update on that. Thank you for raising that.
The second comment in the chat is, will this slide presentation be emailed to participants attending today? I can drop the SHARP webpage in the chat. We do try to post all of the documents to that webpage.
Yes, thank you. And yes, we will be posting the recording of this meeting as well as the slide deck to our SHARP webpage. And we can also send out a email through our Nevada Health Authority listserv just to notify you all that those materials are available. Okay, and then I have another question about speaking to the match requirements anticipated. Thank you for that question. The bill is very specific that match is required for all of these projects. So if you are requesting a project that is supported by, say, $50,000 of SHARP funds, then the project must also carry $50,000 in in-kind or match to support that ask. So we will be providing greater details on that requirement in the RFA itself. But for now, the only advice I can give you is, you know, the bill language has that laid out, and that's that example that I just provided. Let's see. Oh, and then Vance, I see that you asked, will there be any caps on the amounts requested in the RFA process? Another good question. You know, we had talked about this a little bit in our last public workshop. We have not decided if there will be any caps or not, but I can tell you that an applicant should not come forward requesting the entire amount available. I hope that helps. And then Ryan, you have your hand raised.
Yes, hi Melinda. I just wanted to bring up, this is anecdotal, but and I don't know that there's much we can do about it, but I saw in a comparison, we were looking at New Mexico as well for some of the physician shortages. They just announced yesterday, I believe, that they're increasing their tuition reimbursement to physicians to $300,000. They're doing free children health care, and their children have free college tuition as well. So I know, again, there's nothing we can really do about that, but it's going to be hard to compete with some of that. So just wanted to bring that to light.
Thanks, Ryan. Appreciate the comment. Yeah, Chrissy.
Yeah, it's just kind of regarding to other future iterations of the needs assessment, is ED utilization data. I know this is more focused on like primary care and behavioral health, but working for the nonprofit Street organization, but also in several ERs in Las Vegas, many of the high utilizers and the unhoused utilize most of their primary care and behavioral health through the emergency room. So that is like a very large subset that probably wasn't analyzed. I know the hospitals have that data, but maybe the NVHA can kind of drill down into that because it's missing just for needs assessments. So
Yeah, thank you. Appreciate that comment. Let's see. So Dr. Zimmering had asked, so if we were to request 50,000, would we need to demonstrate proof that we already have 50,000? So that talking about the match requirement in that example that I provided. I believe there are some examples in which, yes, that would be. However, there are additional examples in which you could, you know, put forward your plan to provide that match throughout the project. And that's kind of all I can say on that at this point, but I will provide additional details in the RFA once it's released. Let's see. So, and then Casey had asked, as therapists, PTOT, SLP in the communities help to amplify health outcomes and are a proven cost-effective healthcare strategy with demonstrated shortages. Would those be considered, even though they are not in the top 3 areas of need? Thank you, Casey, for raising this. I do know that that is a shortage area. For that, I would just say I would defer to Dylan and Maddie, but I appreciate that consideration, and we can definitely take that into account as we, you know, communicate this assessment and report.
Melinda, there was one more question before Dr. Zimmerings from Shanna. As a nonprofit, would unrestricted donations meet the match requirement, or does the match need to be allocated specifically to the same project?
That is a good question, and I will have to phone a friend on that one. So I will take that down. And we may be actually releasing a FAQ document along with the RFA. So all of your questions, if you could email them to that sharp email that's on your screen, then we can take those in and we can provide an FAQ that will go through each of those commonly asked questions and provide the Nevada Health Authority response to that for you all. So I will look forward to doing that and getting that posted to the website as well. All right. Any other questions, comments, concerns? Okay. Well, thank you all so much for hanging in there with us on this late afternoon. I appreciate you all and hope you have a great rest of your evening and week ahead. So thanks again and have a great one. Thanks, guys.
Thank you.